Welcome to the SCI Forum podcast. This podcast was produced by the Northwest Regional Spinal Cord Injury System in the University of Washington Department of Rehabilitation Medicine. The Northwest Regional SCI system is dedicated to improving the lives of people with SCI through excellent patient care, research, and education. To learn more about our podcasts and videos or to make a donation, go to sci.washington.edu.
Hello and welcome to the Spinal Cord Injury Forum podcast. My name is Jeannie Hoffman and I'm the director of the Northwest Regional Spinal Cord Injury System and a clinical psychologist and professor in the University of Washington Department of Rehabilitation Medicine. As part of our series on the therapists who work with people who have had spinal cord injuries, I'm joined by Leslie Fox. Leslie is an occupational therapist at the Comprehensive Outpatient Rehabilitation Program, fondly referred to as CORP, at Harborview Medical Center. Leslie, thank you so much for joining us today.
My pleasure.
So I want to just get started and find out, what do you have to do to become an occupational therapist? What exactly training, what's the background that you need to have?
Typically, to be an occupational therapist, it's a master's degree, and most programs around the country take about 2.5 years to complete. As of this year, there will also be an option to do a doctorate program. So moving forward, applicants can choose either track, a master's or a doctorate. And I think the goal with that transition is to have more people in the field with a focus on research.
So what made you pick occupational therapy? What was it about occupational therapy that got you interested?
Yeah, so I actually think that I first heard about occupational therapy when I was reading USA Today, and occupational therapy was listed as one of the top 10 jobs in the U.S. And I had recently graduated with a bachelor's in psychology, and I was not sure what was next for me. I started looking into this field of occupational therapy, and it sounded perfect for me. I was really drawn to the fact that you get to work with people and that there's a lot of diversity in the field, so you have a lot of options. Your job could look totally different depending on, where you worked and what type of population you worked with. That was really appealing to me.
You got your master's degree. When you have to do clinical placements for that too, right?
Yeah.
But you hadn't really had any specific exposure to spinal cord injury per se during that clinical exposures, during your clinical training.
During my clinical training, I did meet several people with spinal cord injury and learned a little bit about how an occupational therapist might work with someone with spinal cord injury. But it wasn't until I started working at Harborview that I got more specialized training and exposure and a lot more experience working with this population.
Can you talk a little bit about kind of what do occupational therapists do with spinal cord injury?
Often after a spinal cord injury, there is such a change in a person's physical ability. Our role as occupational therapists is really to help teach people ways that they can do the things they want to do. That might be teaching people new strategies or ways of doing things. It might be learning about equipment or tools they could use. Sometimes it's training caregivers or family members how to help the person do those things. We live in a very independence-focused society, and for most people, being as independent as possible is a big priority. So we really spend a lot of time in helping people figure out the ways they can be independent in their day-to-day activities, as well as getting back to doing the things that they most want to do in life.
Can you give some examples of what an occupational therapist might be working on with somebody with tetraplegia versus paraplegia? Because I think, part of my worldview is that occupational therapists tend to do kind of hand, upper body stuff more than, certainly mobility is important for both, but tend to focus more on the kind of what can you do with your hands and arms. And so what are the things that are different between somebody that has a more a higher level injury, more complete injury versus a lower level, even more incomplete injury?
Yeah, so when we work with people who have tetraplegia, we spend a lot of time focused on arm and hand function. So it may be in the beginning, we're working on strengthening to try and regain some of that function. But then we're really transitioning into what are tools and strategies that people can use to still interact with their environment with their arms, despite not having full finger, hand, arm function. So we'll practice, different ways to grasp things when you don't have finger function. One form of grasping is called tenodesis, and that's when someone raises up their wrist, their fingers passively connect with their thumb to form a pinch, basically. So we will spend a lot of time practicing that over and over and over so that people can still pick things up, even if they don't have finger strength. Mm-hmm. We also look a lot at different tools, things like something called a universal cuff. It can be placed on the hand, and then a toothbrush or a fork or a spoon or a stylus for a tablet. Those things can be placed inside the universal cuff strapped to the hand so someone can use their arm strength, but no finger strength is required to hold the tool. Mm-hmm. So we'll practice with things like that.
So how about with somebody with a lower level of injury where they still have great arm and hand function?
In that case, we're spending a lot more time on shoulder preservation strategies. So someone with paraplegia is now going to be using their arms much more than they did before. They're going to be using it to help move, to propel a wheelchair in ways that they maybe didn't use their shoulders and arms before. So we spend time on strategies to protect your shoulders from injury and to promote long-term health of your arms. We work on techniques for getting dressed, transferring, getting in and out of the bathroom. We spend a lot of time, too, on looking at house accessibility. So as you mentioned earlier, Jeannie, no one is expecting an injury like this, and most often people's homes are not wheelchair accessible. So we'll spend time looking at the person's current living situation to make recommendations of how to make the house more accessible. Or how to get by without accessibility. So sometimes that means different bathroom equipment or different equipment in the bedroom. And then sometimes that means planning for a remodel or looking for a different living situation that's more accessible.
So at this point, you work on the outpatient basis. But could you talk to us a little bit about the difference between kind of what people focus on, what occupational therapists focus on during kind of the acute or inpatient rehab stay versus kind of what are the things that get focused on, or are they the same?
Yeah. In inpatient rehab, there is a lot of time and energy spent on sort of the basics. So starting to learn and figure out how to get out of bed and get dressed and brush your teeth and feed yourself. A lot of time is spent on teaching people about their injuries, so learning the anatomy and physiology and why they're experiencing the changes that they are, and then starting to understand how they can advocate for their health and prevent any other complications after their injury, learning about ways that things might be different and strategies for how to deal with them.
So I'm curious about that because I know that, working on inpatient rehab myself, I always know that occupational therapy is the one to go through the Yes You Can manual and make sure that people have that education. How did that get assigned to the occupational therapy role? Because it seems like that kind of material that you're talking about cover really everyone on the team, from physician to PT to OT to psychology and beyond, and nursing certainly.
Well, that's one of the things that I like about my job the most is that we work in such a multidisciplinary team. And, when it comes to providing education and information about an injury, especially spinal cord injury, I think it's so helpful that we have all these different providers, giving the information in different ways and from different perspectives. And as an occupational therapist, understanding the physical changes that might happen after an injury is so important to learning how to be independent and advocate for yourself and do your daily activities that you want to do.
Yeah, that's great. So Inpatient really focused on kind of the beginnings of how-tos for all of these with this new body, with this new injury. What are the kind of things that you focus on as an outpatient?
So often when somebody comes to outpatient, they may have just recently left the hospital, but then we also sometimes see people who are many years after their injury. And we focus on what the person is most interested in pursuing at that time. So often people have a better understanding of what the barriers might be now that they're home and there's some specific activity or task or goal that they haven't been able to achieve yet. And so we will continue to help them.
Can you give me an example?
So one of my recent clients is a college student, or was a college student at the time of his injury, and his goal is to get back to medical school. So we are exploring assistive technology, ways that he can access the computer, make documents, PowerPoint slides, get information online, really do things without the use of his hands. So that's one of the areas that in outpatient therapy we have a lot more time to address is what are the resources and the technologies that are available today to help someone be more independent.
Yeah, and I bet that is changing every day now.
It is changing so quickly, and it's so exciting. The trend of consumer technologies is hands-free, and this has been really exciting for people with spinal cord injury. It's opened up a lot of doors where technology used to be very costly and specialized and quite prohibitive for people, and now just everyday consumer technology is opening new doors.
Yeah. That must be a fun part of your job, is to not only be able to help people with these things that are just available to anyone, and customize them for people, but also to be learning all the time.
Oh my goodness. Yeah, it is both humbling and exciting. It's something I really enjoy about my job is that I'm constantly challenged. And yeah, there is a tremendous amount to continue learning all the time.
Do you ever find that people have a harder time focusing on some of the kind of, I don't know, tedious activities of being able to brush their hair, brush their teeth versus them wanting to really just spend their time figuring out how to be back online and back connected to, the virtual world?
Yeah, this is where, people's individual differences really come out. So some people are very motivated to be as independent as possible with their self-care, and it's really exciting for them to find new ways to brush their hair, shave, brush their teeth, eat. And other people are more motivated by what ways can they get back out in the community. They want to be connected with social media. They don't mind having some help with some of those basic tasks so that it frees up more time for them to be engaged in other activities that are more motivating to them.
That's great. So really having to kind of sit down with somebody and figure out what is it that they really, really want to do, and not trying to project sometimes what we might think they want on them.
Absolutely. Especially in outpatient therapy, I think people have a little bit better idea of what is the next step for them, what's most important to them, and what do they want to work on. So
absolutely. Always curious because, I've been around long enough to know how short stays have gotten for inpatient rehab. Has that changed what you do in outpatient rehab now, that the fact that people aren't spending as much time in the hospital?
Yes, that definitely has changed where we start and what we pick up when we meet a new client in outpatient. So we may be working on some of the things that they worked on in inpatient rehab but hadn't quite reached their full potential yet. Mm-hmm. So we will very often still work on self-care, getting in and out of bed, doing the day-to-day activities, and then also helping people plan for what's next. What's the next thing to look forward to and work towards, and helping them figure that out.
I'm thinking about people as they age with spinal cord injury. What are the things that bring people back 5, 10, 15, 20 years post-injury?
We see people often many years after their injury when they've either had a change in their physical abilities or their health condition, or just a change in their priorities. And maybe there's something new that they want to be able to access that they haven't figured out a way to do. So there's a lot of different reasons that we might see someone down the line. And often it's by recommendation of their physician that they come see us to figure out some new challenge that they have. So, as people age with a spinal cord injury, as their physical abilities change over time, it can be really helpful to come in and learn new strategies for things like protecting your skin, staying as strong as possible. Weight management is really important. And again, like I said before, just a changing in priorities. So sometimes people would like to spend more time in things like recreation or new forms of employment, maybe new household accessibility questions. So often people will come for an occupational therapy evaluation to learn about ways they could change their house to make it more accessible. We talk a lot about bathroom design, kitchen design, ramp entry, those types of things.
Yeah, that's really cool. I hadn't thought about that, for that occupational therapy tends to be the kind of go-to, because in terms of being able to access your kitchen if you want to get back to doing more cooking or things like that, or having the kind of best bathroom design, oftentimes injuries are sudden and unexpected, and so people don't have the resources necessarily to do a bunch of changes right away. So I could see them coming back when they're ready to actually make those changes.
Yeah.
When do you know that it's time to discharge somebody from therapy?
Often it's when they tell me they're ready. And sometimes it's when they've really reached their current level of potential and it's time to get out there and start living their life and spending more time in the things they want to do instead of coming into clinic for therapy.
Is it ever dictated by insurance?
It is, unfortunately. Yes, insurance can play a role, and it's something we talk about early on in the plan of care. And so if I know that somebody has very limited amount of visits, we might focus on different things. Versus if we have lots and lots of visits, we might have the opportunity to sort of expand our goals and look at more advanced training or opportunities to try things they wouldn't otherwise try.
So a lot of the things that I hear you talk about are overlapping. So can you talk about that a little bit, about how does occupational therapy, physical therapy, all the rest of the team really, it seems like recreation therapy, a lot of what you're talking about kind of goes into multiple domains. How do you kind of negotiate the overlap? How do you think about that overlap?
Well, one thing that's great about working in a rehab facility is that team members meet regularly to communicate and talk about their goals with the patient and what they're working on and the patient's progress. So we're constantly collaborating on that to help people reach their goals. And the overlap is often very helpful. So while physical therapy will be focused on a person's mobility and how they get around, occupational therapy is also looking at mobility because it's required to get dressed or to get to the bathroom or to do what it is that they want to do each day. So I think it provides an opportunity to look at these different functions from different perspectives and with a different set of eyes.
Mm-hmm. It's interesting because I think, again, my experience on an inpatient unit is that people often love physical therapy because it's I'm moving, it makes me move. And sometimes occupational therapy is harder for them because they don't want to focus or spend as much time on the basics. They kind of want things. So do you find that to be true sometimes too, and even on an outpatient basis, or do you feel like that's something that's pretty easy for you to overcome with people?
Sure. No, I do think that there's definitely some glamour in the ability to work on walking and mobility. People are often, especially in the beginning, most focused on being able to walk and get around. That's what feels like the biggest loss, is not being able to stand up and walk around. And I completely get it. And that is just not as sexy as figuring out how you're going to go to the bathroom or how you're going to get that next bite of food to your mouth. So I think, yeah, there's definitely Sometimes what we're doing is not as exciting in the beginning, but I would say over time, I think the focus starts to shift back to like, hey, actually, I really want to be independent with all of my self-care, and this is really important too. So,
Yeah.
yeah.
Yeah. No, I totally agree. It's if you could just follow them in, right?
Mm-hmm.
You can make yourself known. Say somebody's kind of out in the world with a spinal cord injury. At what point should they go, hey, maybe I need a referral to occupational therapy?
So, reasons that people get referrals to come to occupational therapy are really quite varied. So, often it will be if somebody needs a new piece of equipment, especially for their bathroom. So, we do evaluations and make recommendations on what type of equipment someone could benefit from. Equipment changes over time, and what's available on the market and what insurance might pay for is also changing. So, people regularly come in when they need a new piece of equipment, and they want to make sure that they have what's best and going to make things easiest. And then people also come back if there's a new career or profession they want to look into. We also address sexual functioning and sexual health. So sometimes people will come in with questions about that and maybe want some help problem solving or learning about available devices or techniques. We do get a lot of referrals for assistive technology. At Harborview, we're opening a new assistive technology center where people can come in and be exposed to modified workstations for accessing the computer. It's a smart home design setup, so people can trial different smart home assistants where you can control the lights and the fan and the temperature with your voice. We do an adaptive gaming program in the lab as well, so if people are interested in learning about ways to get back into gaming, or maybe it's going to be something new they want to try, that would be a reason to come in. We also might see somebody if they've had a shoulder or an arm injury. So it's really a common complication after spinal cord injury or for anyone using a wheelchair to have, unfortunately, a shoulder injury. And so we may do some rehabilitation with that, strengthening, teaching ergonomic principles, looking at some changes to their home setup that might help preserve their shoulders or help them heal.
Can you also talk about one of the things that we talked about with Jordan is about seating and pressure and all those kind of things. And I understand that both occupational therapists and physical therapists end up being seating specialists. And so kind of what is the occupational therapy perspective, or is that different? Because you guys do a ton of equipment work. And so is that just kind of, does it fall under that as well? Or is there other things that, need to happen for people to become specialists in that?
Yeah, this is one of those areas where it's also really helpful to have multiple disciplines involved. I think occupational therapy brings the perspective of, how is the person's seating and positioning going to affect their ability to do their day-to-day activities. So we're often looking at, is someone needing to maybe cath themselves from the wheelchair? So with the wheelchair setup, are they able to scoot forward in the chair and back? How are they doing pressure reliefs? Do they need to drive up to a table or a computer? What are their work tasks? So we're really looking at those things and thinking about how is their functional mobility from their current seating.
Mm-hmm. That's great. I hadn't thought about that, but it really does. It could change what kind of device that you, or what kind of wheelchair, or how high it is and things like that, if you, need to be able to access certain things.
Yeah,
So
definitely.
So, you mentioned that one of the things that sometimes people get referred for is around sexual health and functioning. And, that's certainly rehab psychology certainly gets those. I know that physicians can as well, especially maybe even urologists, much less rehab. But can you tell a little bit more about kind of what does occupational therapy do in that arena?
Yeah, so things that we typically cover with that, or questions that people often have, are around just practical problem solving. So are there devices that people could use? Are there positioning strategies? We talk a lot about bowel and bladder functioning and how that might impact sexual functioning or your sexual activity. And we talk about how to protect your skin and positioning. We'll often talk about ways you could modify sexual devices for you and your partner. So we sort of, address what the person has questions about, and we really just try and problem solve it as practically as possible.
Do people sometimes bring their partners with them so that you can actually kind of both work on things together?
Yeah, absolutely. I think that's a really helpful opportunity if that's available. And if somebody feels comfortable doing that, then that really allows us to just figure out the solutions that are really going to work. There's only so much that you can just talk about and, sort of verbalize.
Right.
And sometimes it really takes just trying out different positions and helping that person see, yeah, is this going to work? Is this going to work? I'm not sure. Let's try it.
Yeah.
And let's see what's realistic.
And that's so helpful because I think a lot of times there's that worry about like, am I going to hurt this person? And, kind of how does that work? And so that's great. Such an important part of people's life. I'm glad that people are actually thinking about it and working on it.
Yeah, me too. And I think sexual functioning is something that often gets either overlooked or just, maybe people are afraid to ask and providers are afraid to bring it up. But I think it's such an important part of people's health and well-being. And so it's really an opportunity to help people with getting back to a sexually active life.
So how do you bill for that?
So this falls under, an everyday activity. This is definitely right up occupational therapy's avenue. Our job and our role is to help people do the activities that are meaningful to them and to do it safely and independently. And this definitely
and
works.
the reason I ask is that I think sometimes people might feel like, oh, well, is that really, like, would insurance cover that? But I think what you're saying is that it really falls under kind of all of the things that occupational therapy does. So that's great. I mean, because I think sometimes people might not ask because they don't know that it would be covered.
Yeah, definitely. I think there's a lot of education that could be had as well. So just learning about how to stay safe and know about autonomic dysreflexia or protecting your skin or how to manage, bowel and bladder during sexual activity. So these are things that we can really help people navigate, and also sometimes just learning strategies for talking to their partner too. But we work a lot with rehab psychology for that. And I would say another big part of our role in outpatient is to help people connect with resources. So that might be community resources or online resources or just the other disciplines within the rehab world.
So from my experience, I know that there's a lot of building and sewing and all those kind of things that occupational therapists get to do. So can you talk a little bit about kind of the things that you modify, the things that you create for people that are really individual to the person?
Yeah, definitely. So we're often modifying the person's individual tools. So I think just last week I helped someone add a handle to their electric razor so that they could shave by themselves even though they didn't have any grip function. We modify toothbrushes and cups and eating utensils. So yeah, we spend quite a bit of time modifying people's specific tools that they want.
What are the kinds of things that you build for people? Like, so I get the modification, but I've also seen like people need a splint to be able to do a certain task.
Yeah, so sometimes we're building a tool to help someone with, say, writing. So we often make little finger splints and tools that help someone hold a pencil. We'll make tools to help someone with cathing themselves. So that might be also a finger splint that helps them grasp the catheter. But we also make tools to help people clip their pants, to kind of move the pants out of the way and then free up a hand to work on cathing. We modify eating utensils, shaving equipment. I've modified a lot of eyeliner and mascara so that people can still put on their own makeup. Yeah, anything that somebody wants to use, we can modify it.
Right. I've also seen that there's a lot of sewing that happens of like leg loops and bed ladders and other things like that. Are there other things that you think of when you think of like, creative.
Yeah, definitely. I've sewn a lot of wash mitts for people for bathing. We have altered pants just to make them easier if you have to manage a catheter or a leg bag. We've sewn wheelchair bags so that people can hold things right there on their wheelchair.
What's the craziest thing you've either modified or created?
We talked earlier a little bit about how we might help people with their goals around being sexually active. And I did help somebody modify their vibrator to help with that. So this individual had tetraplegia and was not able to grasp the vibrator. So we added on a handle and a strap so that they'd be able to use that independently. I think we also, for this one, added on a bit of a lever over the button because the button was really hard to press. So with a lever, they were able to just put an elbow on it and turn it on and off.
I love that. That's awesome.
Yeah.
It's such a great thing to be able to help people to be more, take charge of their own life and certainly take charge of their sexual life. So that's very cool. Jordan talked to us a little bit about the difference between compensatory and restorative, and you've shared a lot of the great stuff you guys create in terms of compensatory strategies. What is the kind of things that occupational therapists do in terms of more of the restorative or just recovery side?
Yeah, we definitely, especially in inpatient rehab, spend quite a bit of time on localized strengthening in the upper extremities. So that might be designing an exercise program for the hands and arms. We also use something called functional electrical stimulation. So we'll actually apply an electrical current to somebody's muscles to cause a muscle contraction. And in that way, that might be strengthening their muscles, and it can also help with a little bit of return for them having control of those muscles.
I know that there's a lot of effort put into kind of getting people back to be able to communicate with friends and family, which often means getting them back online. So what role does occupational therapy play in that on inpatient rehab?
Yeah, so often we're really helping people use the technology that they already have. So most people these days do have a smartphone, and there's a lot of new technology that enables people to interact with their phone and operate their phone without hands. So we teach people ways to change the programming on their phone or to use switch control. We do a lot of mounting of people's personal tablets and phones, so that it's positioned in a place they can see it and use it. It's so important for people to be able to have some independence. And often in the beginning, being able to independently call your family or check your email online or even call the nurse is really important. So occupational therapists are often involved in helping people do those things.
That's great. So this is patient and family. You've mentioned that a few different times. What kind of work do you do with families?
Yeah, we're really engaged with families, and we really appreciate when family members are able to join in and participate in therapy. We spend a lot of time training family members and caregivers on how to help the patient and ways to keep them safe and ways to also help them be as independent as possible at home. So
one of the things I sometimes see is that people want to do too much for their loved ones. Do you have to struggle with that a little bit, and how do you kind of manage that?
Yeah, definitely. I think one way that we can help caregivers is to let them know about taking care of themselves as well. So trying to avoid burnout and also trying to avoid an injury. So it's really common for caregivers to have a back or a shoulder injury. They haven't been trained or previously been doing this kind of heavy lifting work that might be required. So we'll spend time teaching people safe transfer techniques and strategies. We spend time teaching people about taking breaks and caring for themselves as well, and also how to get other caregivers involved, resources in the community or resources through their insurance. Any ways to help offload the burden of caregiving from family members is sometimes helpful because that frees them up to just be their family and not have to also be a caregiver. So in order to discharge from the hospital, it's really important that we've spent time and fully trained family and caregivers into how to help the patient. So it can be really deceptive in the hospital about how much care is involved day to day, because we have a lot of people helping out. There's nurses and therapists, as well as the family members. So we often on inpatient rehab will have a family member sign up for a day, and for one full day, they will do all of the care involved. So, of course, we're still there in the background to help, and usually we provided a lot of education before this, but we will do trial runs before somebody goes home to make sure that, we haven't forgotten to teach anything, or there's not some area that's particularly hard and needs some more problem solving before they get home.
Because sometimes people think it's easy until they actually do it.
Yes, it's very true. And also, I would say sometimes people think that it's scary or it's harder. And so one role that therapists can play is helping build people's confidence, helping caregivers feel like, yes, you can do this. It's safe. There's a lot of times people feel pretty shy or uncomfortable, or just it's just an awkward change in roles and family dynamics. So, many people need help with their daily toileting programs, and we train family and caregivers to help with that. So I think just getting experience and exposure and normalizing the experience as much as possible can be really helpful.
You had said that, like, when you first got started, you had some exposure to spinal cord injury, but what was it that drew you to kind of become the specialist? I mean, really, you're one of the experts. So what drew you in?
So I love that my job allows for a lot of creativity and innovation and a tremendous amount of collaboration. I am someone who is really motivated to be around people and connect with people, and working with people with spinal cord injury allows for all of these things on a daily basis. I am constantly challenged to find new solutions, figure things out. It's really exciting to see people make progress. So, after a spinal cord injury, sometimes the first time a person is able to brush their teeth is such a highlight for them, and it's so exciting, and the family's excited, and we're excited, and they're excited, and it just keeps going uphill from there. So being able to be part of that recovery and help people reach their goals is really motivating to me and has been a really rewarding part of my career.
That's great. It is pretty impressive. I think one of the things that is so attractive about rehab is just how resilient people are. And I think that's exactly what you're talking about, is that you're then getting to celebrate their resiliency with them, which is fantastic.
Yeah, definitely. I am constantly in awe of people's ability to cope and to bounce back and to even just excel after this type of event.
Absolutely. Well, Leslie, thank you so much for joining us. This has been really informative, and really appreciate you taking the time.
Thank you, Jeannie. My pleasure.
Thank you for listening to the SCI Forum podcast. To learn more or to make a donation, please visit sci.washington.edu.